You're listening to a podcast from the BMA.
The BMA's Humanitarian Fund offers NHS clinicians the opportunity to share their knowledge, skills and good practice with colleagues abroad. It benefits communities in the developing world, and doctors return with an increased awareness and understanding of global healthcare issues. I'm Flavia Munn, and I spoke to Alia Darweish, a Specialty Trainee 5 in anaesthesia from Bristol, who was supported by the fund to work on a project in Uganda. I began by asking her what was the aim of her project.
The initial aim of our project was to decide whether the hospital that we were going to go to was going to be suitable for a training opportunity for obstetricians and anaesthetists from the Bristol region, to form a link between the University Hospital in Mbarara, which is in southwest Uganda, and the University of Bristol training deaneries. And what we wanted to do was evaluate any potential training opportunity and education for our trainees locally, and whether we could help in terms of education, training and clinical input for the medical students and the equivalent training doctors in the hospital in Uganda.
Working in Uganda must have been very different from the NHS. What was it like when you got there?
When we first got there, it was quite difficult. Whilst we were expected, they weren't really sure what they wanted to do with us. We were trying to assimilate the culture and the cultural workings, if you like, of the hospital, and trying to find a way that we could fit in initially. And there was a lot of observations stepping back. And then as they sort of got used to the fact that we were going to be there for a few weeks, it became more apparent that they wanted to see what we'd brought, particularly our educational materials. And we did some early sort of teaching or tutorials with some of the other registrars or the equivalent of a registrar. And then we sort of built a few bridges with some of the key figures, if you like, within those groups, and offered to do a teaching program. And from there, we started having regular tutorials where we would invite the trainees to come for emergency drills training, particularly in obstetrics. And I took some of the anaesthetists and we did some drills training with them. Then they started seeing us putting it into practice on the wards. Eventually, we became more accepted, and from there it was, could you teach us this? Could we do that? Could we go through this again? And the obstetricians have now been able to use the link that we've created to have a fellow to stay in Uganda. So we now have a constant link, if you like, for someone to stay in place in the hospital in Mbarara. But we can also have trainees coming in for shorter periods of time. We're hoping it's going to be a sustainable collaboration between the two places.
What do you think you gained from your experience working in Uganda? Do you feel it made you a better doctor?
It was challenging. I wasn't really sure what to expect. We definitely found it enjoyable, and it's easy to look back in retrospect and say, oh yes, it was all wonderful, but it wasn't. It was hard work, and we have to be really honest that it's not just an altruistic thing. We are doing it partly for ourselves, and from my sort of personal point of view, because where we were working, it was quite difficult circumstances. The doctors were really working with very limited resources. The patients were obviously subject to extreme poverty and hardship. But because of the limitations of what the hospital could offer, because it's so poorly funded, because it's so poorly resourced, you really do sort of live not only by your clinical wits, but also by your professional integrity in some ways, because there weren't many things that I could do as an anaesthetist. I was bereft of expensive equipment. What we could do was just be with patients and communicate with them and talk with them and just basically be what I think it does actually mean to be a doctor, and that is just something that I really learned from this experience. It was very humbling.
Were there any financial or logistical barriers you had to overcome to get the project going?
When we were sort of in the planning stages, we had no way of funding. We weren't really sure how we were going to go about that, which is where we were very fortunate, and the BMA obviously stepped in with the Humanitarian Fund, which has been really incredibly beneficial to the group. We had donations from the families, and friends, and there was meant to be a charitable input, which was able to sort of help us with some fundraising, but it just helped us put together a pool of money. And then, of course, the BMA money came in just almost at the last moment, which was fantastic. which enabled us to pay for our flights and some of our subsistence, because otherwise it would have been all from our own personal funds.
You spoke earlier about the difficult circumstances in which you had to work. How did you cope on a personal level?
We were seeing some horrific things, which I think in the Western world, we were seeing young mothers die, which was very hard, and we were seeing babies die when they didn't need to, and saw some very sad hit-and-run cases with young children being just abandoned on the side of the road with terrible injuries and coming in with no family, no identifying markers. And after about a week of this, suddenly it became apparent that we were getting used to it, which was quite an uncomfortable feeling. What we did do was we took time out and we took time to talk to each other about it. And I would say that we, took solace in each other's company by making sure that we did talk through some of the situations that we were seeing, and we were kind of aware that we didn't know each other completely as a group. And then gradually, as the sort of boundaries came down, we spent more time with each other. It did become easier to talk about these things.
I guess it's difficult to evaluate the impact of the project, but what do you think were some of the most successful aspects?
What we managed to do was, and I think it's probably an anaesthetic thing, I couldn't bear looking at all these drugs disorganised and unlabelled. So I went through as many equipment storages and drugs cupboards as possible and went through them all and worked out what was in date, what was able to be, what we could save and what was safe and what wasn't safe anymore to use. We went through all these cupboards and reorganised all these cupboards and reorganised all their equipment stores and the emergency trolleys. And actually, over a couple of weeks, we realised that they were keeping them in this really nicely organised way, and I think it was quite nice to see. But then they realised the emergency trolley was really useful to keep stocked up and in an accessible place, as opposed to keeping all their emergency drugs locked away, because they realised that through the drills training that we'd been using, that actually they needed certain drugs and equipment immediately to hand, and because we'd arranged this trolley and put it somewhere close that they could get to, they realised they could actually use it. It was accessible and it was available to them in an emergency. So it was small things like that which just gradually will start, hopefully, would have filtered through into their sort of daily culture and just changed a little bit of the way they're practising on the wards.